Hey guys, welcome back to my channel. So this is Dr. Shubham, and today in this particular session we will be talking about the venous thromboembolism, which is also called as the pulmonary embolism. Okay, so earlier it used to be called as the pulmonary embolism, but nowadays we are calling this as venous thromboembolism, right? Yeah, so I know many of you are already aware of this term pulmonary embolism, and we are studying this particular term from many years now. So if you talk about the pulmonary embolism or venous thromboembolism, if you will break down this term thromboembolism, so you will be getting two terms out of this one word, that is thrombo and embolism, right? So thrombo and embolism, isn't it? So thrombo means thrombus. So what happens is usually you must have heard about a term that is DVT, guys, right? That is DVT. DVT is nothing but the deep vein thrombosis, right? And it is very common in the lower limbs, right? Isn't it? So for example, here you can see that this particular leg, if you will focusing on, right, where the arrow is, so here you will be focusing that this particular leg is actually having the swelling and have a bit reddish kind of appearance over here, right? So probably this person is having DVT in this particular leg, and DVT means deep vein thrombosis. So what happens is that we are having the superficial veins and the deep veins. So if the blood is having some kind of clot formation tendency in the legs, then sometimes what happens is that you can see the lower limbs are there, right? Here you can see this in this diagram, lower limbs are here, and in the lower limbs, usually the vein is having the valves. The veins are having the valves, which is actually making sure that there is unilateral means one-sided blood flow which is happening inside the veins. But sometimes what happens is that due to some immobilization, or the persons who are having the occupation of long standing, for example the teachers who are standing for long hours, or some particular job is there where the person is standing for a very long period of time. Okay, so depending on the occupation also, and depending on so many factors, if the person is having the sluggish circulation due to some reason, and mostly it happens due to the immobilization, or after the surgery the person is bedridden, or there are a lot of factors over there. So due to any kind of reason, if the clot is forming, right, if there is a formation of clot, so this clot will not be able to go further, right? Sometimes it happens. So this particular formation is called as thrombus. Everybody knows that this particular complex will be called as the thrombus, guys, right? This is called as a thrombus, and obviously the blood flow will be hampered over here. Okay, and due to this hampering of the blood flow, what will happen, that you can see this kind of discoloration over here. So reddish kind of color you will be seeing over here, and DVT is also having the stages. Okay, we'll talk about that in some other video, right? But the thing over here is that this particular thrombus can lead to the this kind of appearance in the legs particularly. Okay, and you can see the swelling is also seen. Swelling can also be seen over here, right? Now due to some reason, if this thrombus gets dislodged from its location, then what may happen is that it may move further, and it can actually freely move into the blood circulation. And if it will be freely moving in the blood circulation, then what may happen is that it can further block some kind of artery, right? And usually it is seen that it is blocking the thrombus. Here it was a thrombus, and it was moving in the upward direction, and usually it may enter into the pulmonary artery. So here this is the bigger picture of the lungs, and here what you can see is that the embolus, right? Once there is a thrombus, this is called a thrombus, which is attached to the blood wall over here, and once it is dislodged from its location, then it can actually freely move into the blood circulation. That part is called as the embolus. So combinedly we are calling this term as thromboembolism, right? Okay, so this embolus can move further. Okay, so it is coming from the lower limbs, guys. It is coming from the lower limbs, as we saw just now, and then it can actually move into the through the circulation. It can actually move through the inferior vena cava. It can move into the heart, right? In the right side of the heart, it can actually move through the inferior vena cava. Through the inferior vena cava, it can move into the right heart, and from the right heart it can move into the pulmonary circulation, right? And through the pulmonary circulation, you can that it went into the pulmonary artery. It can actually go into the pulmonary artery, and you can see that embolus might be obstructing the blood flow over there, isn't it? So that is the thing over here, and that's how the pulmonary, because it is happening in the lungs, so it is pulmonary. So usually the embolus comes from the lower limbs, right? And usually the femoral veins are there, which is actually from the primary source of the thrombus in most of the cases, right? I hope there is no problem in understanding this particular picture. Once we understood that, so till now we have discussed that how the thrombus can lead to the embolism and how this embolus can further lead to the obstruction in the pulmonary artery, and obviously the person will be having these kind of problems, like person will be having dyspnea, tachypnea, tachycardia. We will be talking about these kind of symptoms later on as we proceed in our discussion further, right? So I hope till now we are clear that how the things are happening in the pulmonary embolism and what kind of things we can expect in the pulmonary embolism, right? So this is the case. Okay, so if we move further in the pulmonary embolism, which is now called as venous thromboembolism, it is having basically three types, guys. It is having basically three types. What are these three types? It is, they have divided it into massive thromboembolism, submassive thromboembolism, and non-massive thromboembolism. So we are having basically three types. Okay, now what happens is, firstly let's talk about the massive thromboembolism, right? Firstly let's talk about the massive thromboembolism. So in the massive thromboembolism, what we need to understand is that we need to actually know 3 or 4 points basically, and these 3 or 4 points will be enough for us to know that what is the basic picture happening in the massive, submassive and the non-massive thromboembolism. That's how we will be able to compare as well. So first let's talk about the massive thromboembolism, right? So in the massive blood thromboembolism, first thing which we need to keep in mind, that is the blood pressure of the patient, right? In the massive thromboembolism, the blood pressure of the patient drops, which is called as the hypotension. So the patient might be having the hypotension or shock. If the patient is presenting with the hypotension or shock, okay, and if you are talking about the thromboembolism, then it has to be massive thromboembolism, but nothing else, right? So it is not the submassive or non-massive, because we will be studying further that in the submassive and non-massive, BP is not the issue. But if the patient is coming to the emergency, and you are seeing that patient is having the lower BP, hypotension or shock kind of a picture is seen in the patient, right? Obviously you need to see other kind of things also, then definitely it is the massive thromboembolism. Second thing which you need to know over here, right, that is the echo, right? So you need to do the echo of the patient, echocardiography. You will be doing the echocardiography of this patient, and in the echo what you are expecting, that is also very important. So in the echo what we are expecting is that what about the right ventricle. So you will be seeing that the patient will be having the RV dilatation. The patient will be having the RV dilatation, that is the right ventricle dilatation. Along with that, the patient, you might be seeing that the patient is having the septum deviation, septum between the ventricles, between the left and right ventricle we are having the septum, So as you can see over here, this is the left ventricle, this is the right ventricle, between that we are having this septum. So septum might also deviate towards this direction, right, because RV will be dilated, isn't it? So that is the thing over here which I want to focus upon. So RV dilatation might be there. Due to the RV dilatation, septum deviation might also be seen. Septum deviation might also be seen in these patients, right? And because right ventricle is getting enlarged, so left ventricle will be small as compared to the right ventricle. So the small LV may be present, right? So small LV may be present over there. So these are the basic echo findings in the echocardiography. So in the thromboembolism patient, you must do the echo to rule out other kind of problems in the patient, other kind of cardiac causes, and to if it is thromboembolism, if you are thinking in the right direction, then these kind of findings you might find in your patient, right? Third thing which we need to see in our patient, that is the biomarkers. And in the biomarkers, what enzymes we are talking about? We are talking about the very important enzymes, that is the anti-pro-BNP, right? Please do remember these enzymes, they are very, very important. So first factor we talked about, that is the BP. If the patient is having hypotension, in the echo the patient might be having the RV dilatation, due to that septum deviation or the small LV. In the biomarkers, we are talking about the anti-pro-BNP, and very popular one, that is the TROP-T or TROP-I, right? If they are coming positive, if they are coming positive, then definitely this might be the case of, if they are coming positive or if they are elevated, they are coming positive or if they are elevated, then definitely it might be the case of massive thromboembolism of, okay. And the next one which you need to talk about, which you need to keep in mind, that is the imaging, that is the imaging. And in the imaging, if we are suspecting and we are very strongly suspecting that this is the case of thromboembolism, then you should go for the CT-PA, that is the CT pulmonary angiography. So you should be going for the CT pulmonary angiography, that is the CT-PA, right, that is CT pulmonary angiography, okay. So please do remember about these things, they are very, very important. In the CT pulmonary angiography, you might see that there could be the clot in the pulmonary artery, right. As you can see in this particular picture, this is the case, this is the picture of CT pulmonary angiography. And in the CT pulmonary angiography, what you can see that this is the pulmonary artery, right, this is the pulmonary artery, this is the main pulmonary trunk, and this is the pulmonary artery, left and right pulmonary artery. So here what I want to show you is that with the red arrow they are showing that, you know, this thing which I am highlighting, yeah, this thing, okay. So this thing which I am talking about with the marker, right. So yeah, so as you can see the pointer, yeah, so this is the, this blackish kind of thing, this is the big huge embolus in the pulmonary artery. So that is the gold standard, CT pulmonary angiography is the gold standard or the investigation of choice in the case of pulmonary embolism. Sometimes you can see the polo mint sign, as you can see over here, you know, the whitish kind of layer which is surrounding this particular part, this is the polo mint sign, right. So you can see that actually it is looking like polo mint, right. So it is the polo mint sign. So that can also be appreciated sometimes in the cases of, while you are doing CT pulmonary angiography, in the cases of massive pulmonary embolism or the pulmonary embolism or the venous thromboembolism, isn't it. So these four things you need to actually see in the patient. So first thing, if the BP is falling or not. Secondly, you need to do the echo and you know, compare the findings, biomarkers, anti-proBNP and the TROP-I, and the imaging, that is the CT pulmonary angiography, right. How do you differentiate this massive thromboembolism with the submassive thromboembolism? In the submassive thromboembolism, again we will be looking the same findings, whether BP is normal or not, right. So in these kind of cases, in the submassive thromboembolism, the BP is normal, right. Second one, RV dilatation is present or not. So in the echo, is there any RV dilatation present or not? So we are seeing that RV dilatation is present. RV dilatation is present in case of submassive thromboembolism. It was present in massive also, but BP is normal in the submassive thromboembolism. Third one, we saw that there was imaging, right. Before imaging, we were talking about the biomarkers. What about the biomarkers over here? In this case, we need to do the, again we need to do the proBNP and the anti-proBNP and the TROP-I. Anti-proBNP or TROP-I over here in this case can also be positive. So anti-proBNP and TROP-I, okay, they might be elevated in these cases also. So only if the BP is normal, then it is the submassive thromboembolism. If the BP is also unstable, that is BP is also on the lower side, then it is the massive thromboembolism, right. And obviously you shall go for the CT pulmonary angiography, right. Now it depends that how strong your suspicion is, right. We'll talk about that also, that how we'll be estimating that this person is having the higher suspicion for venous thromboembolism or having the medium or having the lower suspicion. We'll talk about that through the well score as well. We'll you know, discuss that as well. But for now, these things you need to keep in mind, that while you are suspecting, while you are examining your patient, you need to look for these things if you are looking for the thromboembolism or the pulmonary embolism, right. I hope you are clear till now, okay. And fourth option, obviously you shall go for the CT pulmonary angiography. It depends, right, that whether you want to go for it or not, because if you are having the strong suspicion, you shall go for it, or it depends on the availability also, whether it is available in your hospital settings or not. Third thing is the non-massive thromboembolism. So how will you differentiate between the massive, submassive? Massive, submassive, we know. Massive versus submassive, we know what are the findings. BP is the main factor which is actually comparable over there. In the non-massive one, we shall see that BP might be normal. BP might be normal, which was normal in the submassive also. Second factor, we know that in the echo finding, RV dilatation may not be seen, right? So RV dilatation may not be seen over here, RV dilatation may not be seen over there. Third factor, that is the biomarkers. So pro-BNP and the anti-pro-BNP, right? So biomarkers are also not elevated. Biomarkers are not elevated or negative over here as well. So all the things are normal, and the patient are usually coming up with these kind of things, like they are having the giddiness, or they might be having the coughing, dyspnea, shortness of breath. The person might be having the hemoptysis, right? So they are usually complaining of that. The patient are usually complaining of in this patient, how what will be the presentation. So the patient might be having the fever, the patient might be having the shortness of breath, that is the SOB, right, or dyspnea, or the patient might be having giddiness, anxiety. The patient might be talking about one episode of hemoptysis, right? So obviously you need to evaluate. So hemoptysis might be there. So these kind of symptoms might be there. Other than that, BP and all, chest X-ray finding will be normal. ECG finding you will be seeing, that is also normal. Echo finding you will be seeing, that is also normal. So everything is actually coming normal. Blood test also, lab workup you will be doing over there, they are also normal. So but you are seeing that these kind of symptoms are coming, and these are the recurrent symptoms. So obviously you should think about the pulmonary embolism in those cases also, until proven otherwise, right? So non-massive thromboembolism should be your differential diagnosis in those cases as well, right? So till now I think we are pretty much clear that how to differentiate between the massive versus the submassive and the non-massive thromboembolism or the pulmonary embolism. Okay, so if you understood till now, so please give a thumbs up and write your reviews in the comment section, obviously. Now let's move further and let's talk about the risk factor. So risk factor, if we talk about, so there could be a certain risk factors. For example, there could be the factor 5 Leiden mutation, which is the genetic cause over here. So factor 5 Leiden mutation can be seen, and APLA syndrome, that is the antiphospholipid antibody syndrome, that is the acquired cause for which might cause over here, which may cause the pulmonary embolism. Okay, then the persons who are having the COPD, or the person who are having the congestive heart failure or congestive cardiac failure, the persons who are having the malignancy, right, they are also prone for having the this kind of problem. The person with the kidney problem, and mainly the nephrotic syndrome, membranous nephropathy is the main cause over there. The persons, or the the females who are using the hormonal replacement therapy, they are also very prone for getting this particular thing. The persons who are having the pregnancy, because sometimes what happens is that clot is forming in the pelvic veins. So always the femoral veins are not the source, right? So sometimes the pelvic veins, because they are mostly they are on the bed, and pelvic veins might have the clot formation in the veins actually, and that might convert into the embolus and might go into the pulmonary artery. Okay, so you never know. So that they are also prone for getting this pulmonary embolism, right? So unfortunately, but that is the thing. And most very important, last but not the least over here, that is the surgery. History of surgery. Please do rule out this particular case that the patient is having the history of surgery, especially 3-4 days back. So surgery, and mainly which surgery I am talking about, mainly the orthopedic surgery. So mainly the ortho surgeries, you should be very careful over here, because ortho surgeries are, they are usually working on the limbs, and usually working on the lower limbs and all. For example, total knee replacement, or doing some kind of plating for the fractures and all. So for that, if the patient is in the hospital for around 2 to 3 days, coming days, or 3-4 days, right, depending on their recovery. So it's good to have the anticoagulant running on, or good to have the DVT pumps, so that they are not having the formation of DVT, and we need to check the D-dimer levels as well, so that we are checking upon the DVT progression as well in those kind of patients, so that we shall prevent the pulmonary embolism complication in those kind of patients as well. So guys, these are the risk factors which are actually important for the exam purpose as well. Moving on to the signs and symptoms of these kind of patient, or let me say the presentation part over here, which is also very important, that how these patient will be presenting to you or presenting in your casualty or the emergency room, right? So if we talk about the presentation part, then the patient usually they are talking about the shortness of breath, they are talking about the dyspnea, right? Usually the patient might be talking about the fever, the patient might talk about the anxiety or the ziddiness part over there, right? Then the patient sometimes they are talking about the pleuritic chest pain, that is also very commonly seen, that pleuritic chest pain they are talking about some of the patient. Some of the patient they are talking about the coughing, some of the patient they might talk about the hemoptysis, right, which is the blood, some 1 or 2 drop or maybe more than that, that is coming in the while they are coughing actually. So that is the thing. Some patient might be having the usually tachypnea might be there, then tachycardia might be there, as I was talking about earlier, that the patient are actually coming up with the tachypnea, tachycardia, you are auscultating the patient might be having the rails, right, on auscultation. If you are talking about the massive thromboembolism, then obviously the patient might come up with the hypotension or shock. The patient might be coming up that I talked about the RV dilatation. So due to the RV dilatation, you might please check on to the JVP of the patient, because that might be elevated. So please do look for that. And why we are looking for the JVP? Because we are looking for the RV dilatation. Do the echo of this patient as well. Okay, you might go for the ABG of these persons, and in the ABG you might expect that they might be having the hypoxemia, right? In these kind of patient, the patient might be having the respiratory alkalosis kind of a picture, right? So if you are doing the ABG of this patient, which you should do, so respiratory alkalosis or the hypoxemia kind of picture you shall expect over there, right? Some patient might be having the picture of type 1 respiratory failure, some patient might be having the anxiety and all these things which we have talked about. So generally these are the symptoms, and based upon these symptoms, based upon our efforts, based upon looking at the echocardiography and all these things, we need to analyze and we need to differentiate in our mind that whether it is massive thromboembolism or the submassive or the non-massive thromboembolism, right? And accordingly treat the patient. Treatment part, we'll talk about that in few moments, right? What about the role of chest x-ray, guys? What about the role of chest x-ray and ECG and all these things? So chest x-ray, ECG and they doesn't make much sense, but usually you shall go for it. Chest x-ray, if you are talking about, then generally we are talking about many kind of signs over there. For example, you might see the Fleischner sign is there, Hampton's hump is there, then which is the wedge shape opacity you shall be seeing over there. Then Westermarck sign, which is the pulmonary oligemia in the apex region, right? Then knuckle sign might be there, the Palla sign might be there, the Chang sign, these are some of the signs which you shall be seeing in the patient. But chest x-ray is having not much bigger role as far as if you talk about the clinical point of view. They are much for the historical importance. Talking about the ECG, guys, talking about the ECG is also again not having very much big importance, but obviously it helps you to rule out the cardiac causes. So obviously if you are seeing the ECG, what you can expect actually. So generally we are seeing that in the ECG we are seeing the right strain or the RVH kind of, because we know that the RV dilatation is seen in the pulmonary embolism. So that kind of thing we shall actually expect in the ECG of the patient. So in the lead 1 we shall see the deeper S waves. So that's why we are seeing that. So deep S wave might be expected if you are seeing the ECG. So in the lead number 1, so that is the S1, and what you can see is lead number 3, you can see the deep Q waves, you can see the deeper Q waves, so Q3, and you can see the inversion of the T waves in the lead number 3, that is the T3. So T3 inversion we might be seeing over there. So that's why it is a very popular saying that we are seeing the S1 Q3 T3 pattern, S1 Q3 T3 pattern in the pulmonary embolism or the venous embolism patient, but venous thromboembolism patient, but it is not the hard and fast rule. We might not see same kind of picture in every patient, but yes, in most of the patient we are seeing RVH strain pattern, which is the deeper S wave in the lead number 1. Yes, that can be obviously seen. Along with that, obviously tachypnea, tachycardia will be there, rightward axis can be there, incomplete RVH or the RBBB kind of pattern might also be there, and with that ST T wave, ST T wave abnormality might also be seen. Every patient is different, right? So different kind of ECG might be expected, but this is the common things which I am telling you. S1 Q3 T3 pattern is you are not seeing in the every patient obviously, but S1 in the RVH strain, the rightward axis, these are the things which you can expect definitely in the ECG of the patient, which is giving you the clue. And obviously the echocardiography is very important in these cases, right? So you will be taking the help of a cardiologist and you will be doing the echo of the patient if the RVH is there, RVH dilatation is there or not. So that is that will be telling you whether you are thinking in the right direction or not, right? Isn't it? So chest X-ray and ECG, once we have talked about that, echocardiography is having the very important role in these cases. Now let me move on to the Wells score. Very important for your exam purpose as well. What is the Wells score? Wells score is actually telling us that whether this patient is having, what is the prognosis of this patient, right? What is the prognosis of this patient having the pulmonary embolism? So what is the possibilities that this patient might be having? How strong you are believing that this patient is having the pulmonary embolism? So if the patient is having the clinical signs or the symptoms of DVT, then we will be giving the 3 points to this patient. If the pulmonary embolism is the most likely diagnosis, we are giving the 3 points. For the tachycardia, the patient will be giving the 1.5 points. If the patient is having the history of immobilization or having surgery in the past 3-4 days ago or the weeks ago, then we will be giving the 1.5 point. Again, the patient is having the history of pulmonary embolism or the DVT in the past, then again we are giving the 1.5 points. If the patient is talking about in the complaining about the hemoptysis, we are giving the 1 point to the patient. And if the patient is having the history of malignancy, then obviously we are giving the 1 point to the patient. Then if the total points, if it is less than 2 points, then we are saying that it is a lower risk patient. If the person's points is coming in between 2 to 6, then it is an intermediate risk, and in the high risk there is a more than 6 points. So 0 to 4 points, P is unlikely, but yes, if the patient is having more than 4 points, then definitely PE is likely, and we are going for the CT pulmonary angiography for the confirmation, right? So that is the case over here. And usually if I talk about, if the patient is having the lower risk, low risk, then usually we are going for the D dimer, right? Usually we are going for D dimer, right? And if the patient is having the high risk, high risk for DVT, high risk for pulmonary embolism, you are having a very strong suspicion, you are having a very strong suspect that this person might be having the high risk of pulmonary embolism, then you shall go for the helical CT or the CT pulmonary angiography. Okay, there is an importance of one more scan, that is the ventilation perfusion scan. But these scan we are using for those people who cannot tolerate the CT pulmonary angiography. For example, because in the CT pulmonary angiography we will be using the contrast, and in the renal failure patient we shall not use the contrast, right? In the renal failure patient or the pregnant patients, the pregnancy, we shall not use the contrast again. So in those cases where we shall not use the CT pulmonary angiography, in those cases we shall be using the ventilation perfusion scan as well, where we are suspecting high risk of pulmonary embolism, isn't it? So if the patient is having low risk, think for the D dimer. Again, clinically if you talk about, it depends on clinician to clinician. Some clinicians are directly going for not taking the risk, directly going for the D dimer, directly going for the CT pulmonary angiography. But if some clinicians are thinking that firstly they are going for the D dimer and then they are going for the CT pulmonary angiography. But the main point over here is that CT pulmonary angiography is the gold standard, is the confirmatory for the pulmonary embolism or the venous thromboembolism, isn't it? Now finally, if we coming, that was the investigation part, that how you are actually differentiating the things. So 3 things over here I have talked about: D dimer, CT pulmonary angiography, and the ventilation perfusion scan. I have talked about that, how you are actually deciding that which one to go for. So now finally I'm going to talk about the management part or the treatment part of these kind of patients. So guys, once we made the diagnosis that yes, this is the case of pulmonary embolism or this is the case of venous thromboembolism, we did the CTPA, we found the embolus. Yes, what we need to do over here now, Then guys, we need to go give the anticoagulant. No doubt about that, we need to start the anticoagulant in this patient as soon as possible, right? Please start the anticoagulant in this patient as soon as possible. And among the anticoagulant, we are actually starting the heparin. We are giving the heparin to the patient, right? Usually we are giving the 80 units per kg heparin, or 1 mg per kg, heparin 1 mg per kg, 1 mg per kg heparin we are giving in the form of subcutaneous. That is the route of administration, right? Subcutaneously we are giving that. That is a low molecular weight heparin, low molecular weight heparin, okay? Or you might use the enoxaparin as well. Here what we need to remember is that we need to check upon the APTT levels, and the target will be 1.5 to 2. That we need to keep in mind because we are using the heparin, okay? So that is the key thing over here. Patient, if the bigger thrombus is there, the patient might be thrombolized as well, right? The patient, we might do the thrombolized as well with the help of interventional radiologist, or the vascular surgeon. We might be going for that as well, right? Now the thrombus, thrombectomy I am talking about, sorry. So thrombolysis can be done with the help of alteplase, that is, so thrombolysis can be done with the help of alteplase drug, okay, which you need to give 100 mg IV over 2 hours, okay, 100 mg IV over 2 hours, that is the dose, okay, and you shall give it up to 2 weeks, right? So that is the thing over here. And obviously after that, what we need to understand that we shall go for the thrombectomy, right? If nothing is working out, or the thrombus is much bigger, or the embolus is much bigger, then we shall go for the thrombectomy, right? I mean the embolectomy, or you can say the embolectomy, where we are removing the embolus basically, okay? So that is the thing over here. And where the person, some person might be there who are not tolerating your anticoagulants. The person who are not tolerating your anticoagulant, then we might use the IVC filter as well. So what will be the use is, if you will be putting the filter in the IVC, so embolus will not be able to come into the heart and will not be able to go into the pulmonary circulation, right? So that is the purpose. So IVC filter for those patients who are not tolerating anticoagulants, right? Otherwise, obviously we need to start the heparin in the patient, anticoagulant, we need to start the anticoagulant in the patient, right? Who are not tolerating, we shall go for the IVC filters, right? And obviously with the help of interventional radiologist, we shall go for the interventions. For example, you shall go for the endovascular procedures for the embolectomy, right? So those kind of things might be tried as well. So management very, very important. As soon as you know that this patient is having the or you are suspecting that this patient is having the thromboembolism, right? And according to your well score, you know that this is thromboembolism. Before having before doing the other kind of investigations, you shall directly start the treatment, that is the anticoagulant, and you shall directly start the heparin drip, right? So that is the thing over here. I hope you're clear with this particular topic, that is the thromboembolism or the venous thromboembolism, pulmonary embolism. Let's revise this particular thing with the help of some MCQs as well. So let's try some MCQs, guys, and let's see whether we are able to tackle some of those or not. So first question over here, what we can see is that a 36-year-old woman, she present to the emergency department with worsening shortness of breath and pleuritic chest pain. So we know that these are symptoms. Her symptom began earlier in the day while she was waiting for her bus to return home. She recently returned from China to the US for a business meeting, and she denies any sick contact and has not had these symptoms in the past as well. So history is unremarkable. She is on oral contraceptive, which means that is a hormonal replacement therapy, guys, right? So she is on the oral contraceptive and daily multivitamin she is taking. Temperature is fine, 98.6. blood pressure is also fine, that is, I mean she is not in the shock or hypotension. Pulse is 112 per minute, yes, it is more than 100, so well score if you remember. Respiration is 24 per minute. Oxygen saturation is 89% on room air. Yes, oxygen saturation is on the lower side because she is having the she is having some kind of problem, shortness of breath. And a CT angio was done and demonstrate a filling defect in the pulmonary vasculature. Means what they are talking about over here, I hope you are having you are not having any kind of problem in answering this thing. So she is immediately starting on the supplemental oxygen and heparin, right? So I want to know the diagnosis over here. Yes, so that is the venous thromboembolism or pulmonary embolism, no doubt about that. Let's take on the next question. 25-year-old woman with bipolar disorder and the schizophrenia presents to the emergency room stating that she is pregnant. Okay, she is pregnant. Now she says that she has been pregnant since she was 20 years old and is expecting a baby now. So that she is breathing much harder and feeling more faint with the chest pain caused by deep breaths. Her hospital medical record that she was having the multiple negative pregnancy tests over the past 5 years. Finally she is pregnant. The 20-year pack smoking history is also there. Temperature is fine. BP is 100/60. So BP is also on the lower side and pulse is 110 per minute, more than 100, and oxygen saturation is again 90%. Finger stick glucose, that is RBS, that is 100, and having the large abdominal penis which is soft and non-tender. Legs are symmetric and non-tender. Okay, oxygen is provided via nasal cannula. Urine pregnancy test comes back positive, and urine pregnancy test comes positive, which means she is pregnant. So they are confirming that she is pregnant. Okay, so initial chest radiograph is unremarkable. However, you should avoid the chest X-ray in the pregnant lady. What is the next best step in the diagnosis? So keeping in mind that she is having the pulmonary embolism, no doubt about that. Second thing, she is pregnant. So accordingly, you should think about the investigation over here or the next step, right? So can you go for the CT? Because she is pregnant, I will not think of the CT or X-ray. Can she go for the D-dimer? Yes, she can go for the D-dimer, but I know that she is having the pulmonary embolism, so I want a better test. Best is the CT angio. So if best is CT angio, what else I can do? But I shall go for the VQ scan, that is a ventilation perfusion scan, isn't it? I told you that we shall go for the ventilation perfusion scan in those cases where we are not able to do the CT angio. So if you are not able to do the CT angio, for example in the renal failure patient or the pregnant patient, you shall go for the ventilation perfusion scan where you are pretty much clear that this patient is having the pulmonary embolism, or you are having very strong suspect that this patient is having the pulmonary embolism. Whenever you are having the strong suspect, please go for the best test, that is the CT pulmonary angio. That is the best. Or if the patient is not compatible with CT, then you shall go for the ventilation perfusion scan. Okay, if you are having the mild or medium possibility in your mind that this might be the pulmonary embolism, then you shall go for the D-dimer. Otherwise, go for the CTPA. Let's take on the next question, guys, over here. So a 43-year-old patient woman, she presents to the primary care physician with complaint of mild shortness of breath and the right-sided chest pain for 3 days. Now she reports that lately she has a nagging non-productive cough with the low-grade fever. On examination, her vitals are like temperature is 99.1 and BP is 115/70. Pulse is 91, respiration 17, oxygen saturation is also fine, that is a 97. She is well appearing with normal work of breathing, no leg swelling. She is otherwise healthy, no prior medical history, right? Now, no prior medical or surgical history, no surgical history, currently taking no medication as well. Attending, it has a low suspicion for the most concerning diagnosis. Concerning means pulmonary embolism diagnosis, but having the lower suspicion. For the lower suspicion, what I told you, for the higher suspicion, I told you CT pulmonary angiography. If patient is not compatible with the CT pulmonary angiography, you shall go for the ventilation perfusion scan, for example in the renal failure patient or the pregnancy patient. Here the patient they are talking about low suspicion for the most concerning diagnosis, right, and would exclude it with a very sensitive though non-specific test. Very sensitive though non-specific. Very specific is the CTPA. If you talk about the CT pulmonary angiography, guys, CTPA is having the 90 to 95% sensitivity and the specificity. Okay, so over here, what would be the very sensitive but not very specific, and have for the lower suspicion, what investigation we are doing? We are doing the D-dimer. So that would be the correct option over here. So order a D-dimer in this patient. Okay, so E option I'm talking about. So that would be our correct choice. Okay, so I hope you enjoyed the discussion thoroughly. If you did, please hit the like button and leave your reviews in the comment section below. I would be very happy. and I would be seeing you in the next class with some other topic. And if you want me to record some particular topic which you find difficulty in reading, so please let me know in the comment section below. I will try to make that on make the video on that particular topic as well. Thank you for today's one, and thank you for your patience as well, and I will see you in the next one. Thank you.